So talking back to the difference between being a patient and being a participant. So there's times when enrolling patients is justified. So when is it justified to enroll your patients? When it's minimal risk. So we want you to fill out a survey. We want you to have a lab. Maybe just get an extra tube of blood when you're already getting labs drawn. Or when the physician is really uncertain, like I am truly not sure if standard therapy is any better than proposed investigational drug device protocol. Maybe I'm treating a disease for which there's standard of care, but it doesn't really help very many people. And this is based on the physician's own clinical medical judgment. And then there's also clinical equipoise, where it's not only that the physician is truly unsure, but where the whole clinical medical community is uncertain about whether standard therapy is any better than the proposed investigational drug device, etc. Again, this is whether there is an effective standard of care, and this is more evidence-based than individual judgment-based. So therapeutic misconceptions, when we talk about that, what are we talking about? There's a failure to appreciate that randomized control trials impose guidelines on practitioners that interfere with direct therapeutic care. So therapeutic misconception is the belief that the purpose of a trial is to benefit the individual rather than gather data. So let's say my neurologist had really explained to me, I'd like you to participate in research, but I think, well, if my physician, he knows about my headaches and is explaining it to me, he must be doing it because he thinks it's going to help me. So sure, I'll do it because, having migraines is terrible, so sure. That's a therapeutic misconception where I'm enrolling in research. Even though I've been given a proper consent, I'm not enrolling with that proper research understanding. I'm enrolling because I still think it's going to help me. Again, it's a belief that research will provide therapeutic benefit. So is there consensus? Is there a uniform belief about what the therapeutic misconception is and whether we should be concerned about it? Again, the therapeutic misconception means not understanding that research is aiming at generalizable knowledge. It's not me thinking this aims at fixing Leah. So we need to keep the purpose of the research clear. The dangers of this is that patients may react primarily to the therapeutic intent, or that the study personnel may sort of imply therapeutic potential. I might say, well, I don't really, I don't want to participate in research. I want to just have clinical care. And maybe the study staff says, well, I know you get a lot of migraine. Then I might think, well, that sort of is implying to me it's going to help. A bigger problem we have with a lot of patients is if you say to patients, why are you enrolling in this study? And this happens a lot with our cancer trials. We'll say, they can verbalize, this is not to benefit me. But if you say, why are you enrolling in research, what will they say? Well, I feel like it might help me. If we say, that's not the reason, well, I know, but maybe it will. And is there a time we should be concerned about that? Like if someone could say, I understand this is for research, you're trying to generalizable knowledge, blah, 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 you've already told me that, but I'm enrolling to help me. Should we be concerned about that? They're showing us they have therapeutic misconception, but they also understand what's on the consent form.
Well, what typically you would do if you were considering someone in setback, you would say, well, this may or may not help you, but more so it may help your grandchildren or somebody in the future because that's how this data will be used.
So are we concerned if they think it might help them?
Well, there's that sometimes a 50-50 chance if it's placebo.
Well, but 50-50 chance if they get a placebo or not. Does the chance of getting the active medication the same as the chance of improvement, of help to them? No, because usually if it's a placebo-controlled trial, that means we don't know if the investigational thing works. Yes?
Are they not discouraging placebo anymore?
The question was, are they not discouraging placebo? They discourage placebo when we have something that has some proven efficacy. We really only use placebo when we don't know if anything works, we have something that doesn't work. Generally, it's more common now to have sort of standard of care versus active medication. And that's only like for patients who have already failed chemotherapy, things like that. Because again, if someone has cancer, we're not going to give them the opportunity to not get standard of care just so we can get our research data.
I think that somewhere there's an argument where you can have the clinical drug, and instead of using a placebo, why not use the existing drug?
Right.
That can cause injustices if you just say placebo, and they're all subjected to the same, the kind of diseases.
Right. The comment was, isn't it more common now to test sort of the active drug versus standard of care? And I think yes, there is, especially if there is some standard of care. And the only time we would allow that is when the standard of care has already not worked for a specific patient. Or often in oncology trials, it'll be, we're going to do the standard chemotherapy plus a second thing versus just the standard chemotherapy. Because we don't, if we have some sort of treatment, even if it's not very effective, we don't want to withhold that from anyone. So placebos are maybe for, things that don't have standard of care that we're really just trying to see, or placebo versus vitamin C supplementation, or like things that we really aren't sure what the effect is. Definitely, it's not ethical to offer placebo when there's standard of care. That was the big problem with Tuskegee. We didn't even offer placebo. We just didn't tell people they were sick so that they couldn't get standard of care. If you take one thing home today from our time together, it's don't do that. Okay.
Can research participants have therapeutic misconception after they receive results from a trial they participated in?
Well, number one, people can have therapeutic misconception all the time. And it's very hard to control the beliefs that we have because we are strange and flawed creatures who hold all kinds of beliefs. It's also somewhat unusual that, I guess, when they talk about results, I assume that means like whether they got the placebo or the active drug. It's very unusual to give a research participant actual results of the research. So I'm not exactly sure what they're asking there. Maybe they can give a follow-up. But if you say, oh, you got the active medication, you got the thing we're testing, and they say, oh, then I'm totally going to be cured, even though we've explained to them, we don't know if this works. Absolutely. People have the therapeutic misconception all kinds of steps along the way. And that's part of why it's really challenging. What do we do when we are giving people clear information? And they sort of seem to be understanding it, but they also have this sort of fallacy of thinking in their minds. How far do we need to go to really correct that thinking that is not quite logical? Was there any follow-up there? No. Other thoughts, questions? So I'm a big fan of, if you are working for a clinical physician or a clinical I was going to say clinical clinic, which is terrible words. If you are working in the sort of patient care realm, you're not just in a research lab, I really, really support having your research study run by a different person. Even if your physician is the PI, a whole different human should come in to speak to the potential participant, to make it really clear, this is your clinical care and your clinical nurse, and this is our research person. The patient still might have the therapeutic misconception, but steps should be taken to really emphasize the difference, and to also emphasize this is not your doctor asking you, this is our study staff. So to make as much differentiation, like it's okay, because sometimes it's easier for patients to be recruited when they are at their clinical appointment. So I'll allow that maybe that's a necessary thing to do. There's an extra obligation to really make clear to you, you don't have to say yes, we won't be hurt, this is totally optional, and it's to help us have generalizable knowledge to help people in the future. Studies that have the physician, who is the treating physician, also enroll in research, I'm generally against those. So what the therapeutic misconception is not. It's not just, oh, I've sort of underestimated the risk. I've overestimated the benefits of this. It's not just saying, I understand that this probably won't benefit me, but I have a hope that there's that tiny sliver that it might help. Because people are human, humans are human, so it's okay for them to have that tiny glimmer of hope. Nothing wrong with hope, but that's different than saying, I'm enrolling in this non-therapeutic trial because I think it will be therapeutic. It's again important to point out to your potential participants that research uses unproven methods or unproven substances more than methods, while standard medical care generally has evidence base behind that this will work for you. Research can be risky, but also so can standard medical care. Part of the reason we're doing research is because either standard of care is not very effective or it has terrible side effects, and that we need something better moving forward. So it's okay for people to agree to things even if they have risk, because our hope is that the risk is actually less in the long term, that we turn out a therapy that works better for people. So how common do you think therapeutic misconception is? Pardon? Oh no, okay, she looked at the slide, I know I shouldn't ask questions like when I'm on the slide, because I would look at it too. So we'll just say therapeutic misconception is extremely common. I apologize for this terrible statistic that goes from 30 to 90%, which renders it practically pointless. Between 3 out of 10 and 9 out of 10 people exhibit the therapeutic misconception. Depends on the type of trial. This is a bunch of trials lumped together, but I think it's fairly common. 85% of participants fail to cite, let me get the door closed. So 85% of participants fail to cite research-related disadvantages, risks of their participation. This is part of our failure of consent, is especially if anyone's involved in oncology trials, we give people like 40-page informed consent. People don't read our 5-page informed consent, and so they're really not reading our 40-page informed consent. So it's sadly not surprising that they can't really talk about the risks and benefits. Up to 90% cited, well, I'm enrolling in research because I really don't have better option, or that they are unhappy with their current option and just hope this is going to be better. But at least up to half, still kind of a terrible number, we're aware that palliation, going without trial, just getting sort of care for their symptoms and comfort for their disease was an option. Up to 70% say they enrolled because they trust their oncologist. And again, this is a misplaced trust in certain ways, because it's trust that people are enrolling is trusting their oncologist is doing something that will benefit their own clinical care, and that's not the case. This is to help future patients for the most part. Occasionally, in oncology trials, there is the potential, more than occasionally, we're testing chemotherapeutic agents, and it might help these patients. But sometimes we're just doing, sort of early phase trials where we're seeing, are they safe before we even see if they're effective. And again, this is trusting your physician as your clinician, which is a different hat than your physician as a researcher. So why might someone want to be a research participant? Part of it is to have access to treatment, have access to the latest treatment. Say you have a disease for which there is no standard of care, or there's a standard of care but it hasn't worked for you. To learn something about him or herself, I used to do research on a rare disease, and we would do a lot of genetic sequencing. And a lot of patients would enroll because they wanted the results of the genetic sequencing. And when I said, I'm sorry, we can't share those with you, they would decide not to enroll. And then sometimes to help healthcare professionals learn about a condition or treatment. I have a lot of family who has a terrible earwax, and I really want to help the scourge of earwax, to vanquish it from this earth. Are any of these good reasons or bad reasons to enroll in research, and do we care about people's reasons for enrolling in research? as researchers, study staff, PIs, do you care?
Well, you should, because that helps you, the way you form your consent. I mean, it makes you be aware of those, and that you have to somehow express them in your consent process, in your consent form.
Okay, we have a comment that it's good for us to know why people are interested because that helps us gear our consent to what their concerns are.
Well, not gear it, but make sure that we're conscious that people have the potential interest, to make sure that they really understand what the benefits and the risks are.
So to make sure that we understand what people's concerns are and we are addressing them with our consent language, what our risks, benefits, alternatives are. Other thoughts? Do you care? Should we care? Are there reasons that are not good reasons to enroll in research?
Just for the money.
Okay, so the comment is, it's not, just enrolling for the money is not a good reason. Do other people agree, disagree?
If you're making the decision for yourself, I don't think it's the same as if you're making the decision for someone else.
Okay, can
For
you,
the money purposes. For example, if I was enrolling my child because I want $50 versus I want $50, so I'm gonna enroll myself. I think it's a little different.
okay, so we now have someone voting for, if you're enrolling for yourself and you're enrolling for the money, you are not concerned. But if you're enrolling your child or ward for the money, that's not a good reason?
It
feels very loud.
On the whole, Nuremberg, when, if you wouldn't do it to yourself, you shouldn't be doing it to other people.
Okay, is there a difference between I wouldn't do it for myself versus this is a trial for kids and so I can't enroll myself?
Well, obviously you can't enroll yourself as a child, trial for kids. But I just feel like, it's not a big difference, it's slight, but it's something that could turn into, a sliding slope if people aren't aware of it. The reason people do things is important.
Okay.
It should be considered, but to what extent is a slippery slope?
Right. Everything in ethics has a slippery slope. So the comment was we should be concerned about why people are enrolling in research, but we're not sure at what point our concern should say, no, you can't enroll in research, but that you do have a higher bar for enrolling someone besides yourself. For yourself, if you want to enroll for money, have at it. All right, other thoughts?
Also, if you as a researcher also, sometimes you have to care about why somebody is participating because a clinical trial could have certain steps.
Mm-hmm.
So somebody is expected to follow through for the trial to be successful. And if the person is just coming in for the money but is not actually serious about going through with the trial, then it could actually hurt the research in the long run based on what the person is actually doing, like maybe it's a medication that the person doesn't follow through, but then it's still giving us data which is going to be inaccurate data. So as well as a researcher, it should matter why somebody is participating.
Okay, so this comment was, it should matter why someone is participating, because if they're just participating for the money, perhaps they haven't paid attention to their 3 study visits, or you're going to have to fill out 900 pages of forms. And obviously, if someone doesn't understand what participation involves, there's a higher likelihood of them not following through on all the steps.
Even medication, they might not even be taking the medication as they should. And it's still contributing data which is going to be inaccurate and mess up everything.
Right. It's always a problem in research, especially research that involves more than people coming and doing one thing. Is how do we get patients, participants who complete the research, do all the steps? In IRB, I'm on, until recently I've been on 2 IRBs here, now I'm on 1. They have to submit a form about every time a patient didn't was not in compliance with the protocol. And so some of them, like we see studies about like food allergies at children's, and so a lot of them are like you have to take a tiny bit of peanut every day for 60 days. And there's all kinds of violations because we have to do something every day for 60 days. That gives us 60 chances to not follow through. So we want people to know ahead of time. Does that matter? Is it different between what their reasoning is, or is it just important that we tell them, like, look, you're going to have to do this thing with a tiny bit of peanuts for 2 months?
Well, I guess it's balancing the importance for who? For the research sake or for the participants? And I think you have to balance those two things because medication or interventions happen in the real world.
Yes.
So you have to know that data. You have to know when people are not compliant. So, I mean, I guess it's just the perspective of how a researcher sees it. Is that useful or not useful data?
Right. I think it's definitely true. She said we have to know when people are compliant or not. Absolutely.
Especially when we know that there are statistical analysis procedures that can control for those factors.
Right. That if we don't know when people are compliant, that's going to screw up our statistical analysis. Then our data is not going to be good. Then our publication's not going to be good. Then other people can't use our generalizable knowledge. So.
But the reality is that people in the real world, even when it is an evidence-based intervention, and it's standard of care, and it's good for you, we all know we should eat 9 servings of vegetables every day, but none of us do, and we have the data to show that. And there's a lot of research trying to do how to change that.
So the comment was, even when we really know something is good for us, we don't do it. We know about, we should all be exercising every day and eating fruits and vegetables, and we don't all do it. We've been enjoying Tootsie Rolls. That is not in the...
That's not why I brought it up.
Tootsie Rolls are good for our psyche. Increase serotonin. So, any other thoughts? I think this is a harder question than it looks like on its face value, because someone could want to participate in research just for that money, but they could be super motivated to be super compliant because they want their $50. So I think we have to be careful about saying, well, your reason for money makes you could say, well, I don't know if ethically I feel okay about that, but to say that makes me feel you're not going to do as well, we don't really know. Because people are compliant and not compliant for all the variety of reasons. We can all think of in our own lives things that we haven't followed through on. It's not always because it wasn't important to us. It's because there's always a lot to keep track of. I think that it is a slippery slope about why someone's participating in research, and because it can get to be that patients are sort of damned if they do and damned if they don't. Like if you're participating because you have cancer and we're studying chemotherapy, and you want to participate because you think it might help you, and it's really not going to help you, and we say, no, I don't know. If you're in it for yourself, that's not right. On the other hand, we say, this is a phase 1 and we're just testing the safety of chemotherapy, why would you want to do that if you don't have cancer? Like it's getting to be where there's no right reason to participate. So I think this is the importance of having a good consent, having a good research oversight, and then to a certain extent, if people are informed, none of this applies if people aren't informed. If people are informed and feel it's right for them, I think we have to really think about whether it's appropriate to be concerned past that. So other factors in communication, part of the challenges of enrolling people in research is that psychology might interfere with reasoning, and this isn't like, oh, those people, they're so simple. This is just, we all have really complicated thought processes. That participants may register optimism and hope and not understanding, and the study personnel might be like, I need 2 more patients to participate. This person wants to do it. They're maybe a little bit overly optimistic, but is that really my job to crush their hope? What's wrong with hope? Individuals can overestimate their protections and strengths and underestimate sort of vulnerabilities. They might think, well, if researchers are doing this, I'm sure that it can't possibly be harmful. I'm sure that they have tested for everything, you know, they know it's not going to hurt me, and we don't because it's research. It is really complicated to help people understand research participation because it is complicated. Like, we have some reason to believe it's going to work, but we don't really know. And we have some reason to believe it might help you, but we don't really know that either. And how do you tell that to people? Say, we have done our level best to figure out if this is going to hurt you, but there's so much we don't know. How do you sort that out? We're all going to interpret that differently, just like we all interpret, there was just that lottery that was like $1 billion. And really, it's probably just as useful if we all take $1 out of our pocket and rip it into tiny little pieces versus to go buy our lottery ticket. Yet I have a friend, and every time there's a big lotto, it's like, oh, let's go buy tickets. Even though the bigger it is, the even more remote, like, I think you have a chance of being struck by lightning twice. That is an unrealistic optimism, if ever there was one. But we don't say, like, okay, who bought a lottery ticket? All of you. You give me $1 right now because you clearly cannot take care of them yourself. Like, we don't say that, but it's pretty much true. So it's a fine line. Like, I generally don't buy tickets, but if I had been near the gas station that day, totally would have. Is that reasonable in any possible way? It is not. Would I want you to keep me from it because it's crazy pants? I would not. I mean, buy my lotto ticket. So let's turn to research design. Yes. Sure. What are the right reasons to participate in research? I generally have a rule that people should only ask me questions I can easily answer so I don't look silly. That is not one of them. I think that's part of the problem, and that's where I talked about patients are damned if they do and damned if they don't. Because let's say I had filled out that form when I went to see my neurologist, and I participated in research because it was in the stack of forms. Was that a good reason to participate in research? Some people would say, well, sure it is. You are benefiting from migraine research. You would like to have fewer in the future, and you signed it, and you're a grown-up human. On the other hand, what could people say? You were tricked. You didn't know what the heck you were doing. You thought that was for your own care. You just didn't notice that it was a difference between clinical care and research care. So what is appropriate? Do you have an idea? No. Any other people have an idea?
When you understand that it will contribute to generalized knowledge.
When you understand that, okay, the answer was, so everyone can hear it, so we can think about if we agree and find flaws in it. Say it again, I'm sorry.
When you have an understanding that the research will contribute to generalized knowledge.
Okay, when I have an understanding that the research will contribute to generalizable knowledge. Okay. What if I have that understanding, but I also have a really outsized hope it's going to benefit me? Like my outsized hope in winning the $1 billion. I'm sure my one ticket, because I only ever buy one, is going to be the path to success. Just like I'm sure that I understand you're trying to study a bunch of people with headaches, blah-de-blah, yakety-schmackety, but I really know it's going to help me. Is that troublesome, or is that I have met your goal, but I also have this therapeutic misconception. Is that concerning to anyone, or is that an okay reason to?
I mean, I think it's okay that you have anything else to lose from, you know what I'm saying, as long as it's not a life and death.
I mean, I don't know. I could get sick from whatever they're giving me. Let's say they're trying a new a medication.
But I think it goes against what we just talked about, autonomy. I mean, if I explain to you in written form, and you know that's not going to benefit you, and you still have hope in your heart, I mean, no one can dictate that.
But then do I really know?
When you give your signature.
But then do I really know it's not going to benefit me?
I mean, if I have explained to you and you have the capacity to make decisions on your own when you're 18, and I'm telling you there's like
no benefit for you, and inside of your heart you have hope, and when no one can take that hope away, and I can't tell you because of your hope you are ineligible for this study.
I think that's the question. What would some people say? They'd say, she's not understanding because if you tell her it's not going to help her, and she says, okay, I understand it's not going to help me, and you say, why are you enrolling? And I say, because I think it might help me. Yes.
Why in the consent form, like say, this study may or may not benefit you?
Which is what it should, so he said it should say in the consent form, this may or may not benefit you.
But may benefit the condition that the person you are
Right,
in the future.
might benefit future patients with migraine or earwax or what the heck ever. So I've read that, I understand it, but do you need to really check that I have swallowed it, or if I still in my secret heart know that you want me to enroll because you secretly know it's going to cure me?
I think that's what consent is a process. It's not a one-point thing of research. There's not one, in the late 80s, when ADT was being tested for AIDS patients, there was not one of those AIDS patients that didn't have that hope. And they knew there was no other treatment. There was just no other treatment for that disease. There was no one AIDS patient that didn't sign up for the clinical trials with that specific hope.
So the comment was before we had the medication to treat AIDS and HIV, that everyone who signed up for a clinical trial was signing up in the hopes that it would help them.
Yeah, I think every person that signed up for an ACT clinical trial had a sliver of hope that it would help them. But they also had the understanding that nobody knew if it would. And because there was no other medication, nobody knew
Do you think they all had the understanding it might not help them?
I think that the research, clinical trials, informed consent, what they did is they tried to do it as soon as ACT has really bad side effects. It's not an easy clinical trial to be part of.
Yeah.
So at every point in the process, there was that reiteration and the presentation of the option to exit the study. So I think that's why all of these elements to protect that, they kind of work in concert. It's not just getting the signature and, you're finished and you're in the study forever. I mean, it's a constant relationship.
So the comment.
With your subject.
The comment was this is part of the work of informed consent, and why it's a process is to continue talking to your subjects about this is what we're doing, this is what we've learned, this is what the purpose is.
Clinicians almost had to kind of reconsent at every clinical visit with their AIDS patients.
I think it is important to have a continuing conversation, and I think it's a really good question that came asked, and I think it's not a question with one answer. Because some people will say, well, if it's really not a therapeutic trial and you're enrolling for therapeutic purposes, then you're still not understanding. And some people say, like, look, you're an adult with autonomy and capacity, and we explain things to you and you seemed understanding. If you want to have hope, we'll go right ahead. We all have outside. I do think it's a fallacy to say, like, if you have outsized hope, you do not have a logical thought process, because we are all irrational about certain things. We're irrational about different things, but look at my thing about the Tootsie Roll. It is, I hate to say irrational, because I think it's totally true. Look it up. Try it yourself. But it's ridiculous. There's people who's like, oh my gosh, she's still talking about it. So we all have our irrational things. Hopefully this does not mean I lack capacity, but there's some things that even if, I have understood, like with the lottery ticket, I understand the chances of me winning, especially when it's $1 billion or whatever, and I buy a single ticket, are astronomical against me. There's not a chance. There's more chance, again, that I'm going to be hit by lightning, but I might buy a ticket anyway. That is, not a logical, good thought process. But no one's going to be like, you should have really appointed a surrogate for her. Did you hear about the lottery ticket buying? So we all have some of that, and it's the point of when are we concerned? Do we care about at all? Like, if we want people to participate in research and they seem to understand, but they have some little irrational thing, do we care? Because I do think there's an argument, like, why would anyone participate in research if not for some hope of either serving themselves or someone, you know, that's like them, a loved one with a similar disease, things like that. I don't know. So research design is an important part of ethical research. It starts from, and I'll talk about this later, but certainly I encourage people to have research ethics involved even when you're just putting your research together, because we've been talking a lot about how important things about like consent are, subject selection, remuneration, how much we're going to pay people. This is all ethical questions that are before you even start your research. So research has to be beneficial. What does it mean to be beneficial? You have to pose a valid and important question. What are you trying to find out from your research? This was sort of another, well, this was certainly a problem during World War II, during the Holocaust, is a lot of these quote-unquote research, it didn't really ask a question, like, oh, I'm really interested in finding these things out. It's like, it was more about, like, what are the differences between twins? Will one die faster than the other? Like, those are not good research questions. So what is a good research question? It needs to answer something that is worth answering. Not just like, I'm curious how much vodka a dog can drink before it passes out. That is not a good research question, and you should not look at it. The methodology must be sound. We talked earlier about randomized control trials. When are placebos used? We don't use placebos when we have a standard of care that has been proven effective. We use placebos when we don't have that. We never want to withhold sort of standard of care from people when we know it works. Confidentiality and privacy must be protected. We need everyday data and storage protections are becoming more complicated, and that's something else that's changing in the new Common Rule. Because it used to be we would tell people, well, you have to anonymize your study samples. So they'd like take someone's name off it, and we'd say, well, that's done. There's no way people can re-identify them, and now we know that's not true. Even if your name is off your blood sample, if we have your DNA and your medical conditions and your ethnicity and what city you're from, there's ways we can re-identify you. And so there's ways we need to explain that to patients better than we have in the past because the science is changing. And of course, you need to follow HIPAA regulations. Just a note, because I think there's a lot of confusion, HIPAA applies to researchers and medical institutions and physicians. Patients don't need to follow HIPAA with their own information. Patients can violate HIPAA. If I've told you all I'm a migraine patient. I can do that. I can tell you my social security number. Like, I don't need to protect HIPAA for my own self. That applies to medical providers and medical institutions. And also medical providers can share information with each other in order for patient care. I think there's a lot of misunderstanding about things like that related to HIPAA. So the potential yes. You don't need to be sorry about asking questions. Oh no, I'm making her think.
So what if someone like you violate HIPAA tells them about a medication that, and then you go tell someone else, like tell your boss or something that say you have a contagious skin condition, and you share that with us, and you go report it to someone.
You can do that. We're not protected by HIPAA right now.
Okay.
So if I've told you something and it's not, it's not as part of your job, it's just regular everyday information. It's not protected in the same way. If I came to see you, let's say one of you work in my primary care office, and I came to see you about my skin condition, and you went home and you said to your husband, oh, Leah was in the office today. She's got some leprosy. That is not okay. But if I came next door and I was like, oh, I've got some leprosy, and then later it's like, oh my God, Leah's got, you said it, that's okay, because me talking to you in the yard is not protected by HIPAA. Me talking to you at the doctor's office is. Yeah. Other questions? So the potential benefits to participants and the society must outweigh potential harms. Again, this doesn't mean for an individual patient, sometimes the harm might be more than the benefit, but as a general, generally applying to the research as a whole. So this is sort of proportionality, what's our knowledge of the risk, which we generally, by the time we've run some animal studies, read the research, we have knowledge of what we think the risk will be. Revisiting the therapeutic misconception, benefits the participant and the society, future patients, are different and should not be blurred in the protocol or consent form. So that's kind of what you had brought up earlier. We can talk about, we hope to gain valuable knowledge about treating your disease. Patients with migraine in the future might benefit. Those are things that are acceptable to say versus, you know, all patients with migraine are going to benefit from this research because we don't know. The balance of potential benefits and harms must be equal for all arms. This is part of why we cannot give someone a placebo when we know that there is a standard of care that actually works. Because then we know some patients, this was way back like 2 hours ago when we heard about that neonatal study, we didn't tell people that the balance of potential benefits and harms were not equal for all arms. And that physicians were not going to make that decision. So if we know, oh, well, some patients are going to get placebo and some people are going to get amoxicillin for strep throat, the potential benefits and risks are much different in those because we know that amoxicillin is a good standard of care for strep. And if you don't have treated strep, you can get secondary complications, you can get rheumatic fever, so that's not an acceptable study design. I hate when people put up these charts that are hard to see from the audience, but I also really like flow charts, so maybe look at this somewhat on your own time. But again, you know, are we doing therapeutic or non-therapeutic? Therapeutic is there's a potential for you to benefit, say like with HIV patients getting AZT, and non-therapeutic is there's not a potential benefit. We're seeing if people can really, if it's safe and effective to give people this dose of medication, things like that. And so if we're doing therapeutic, are we in clinical equipoise? We're not sure which is better. Is it consistent with competent care, and have we balanced the risks and benefits? And sort of a non-therapeutic, have we used sound research, scientific design? Have we balanced risks with the knowledge to be gained? Do we have a vulnerable population? We know right now there's only a couple that are defined by the regs, but still we're going to be careful about other groups. And so you can go through and see if it's acceptable or unacceptable. So balancing risks and benefits is not just something you do before the study begins. You need to continue this throughout the study. Because often, even though everyone's doing everything by the book and completely appropriately, we're going to get new information as we continue with the study. Because we have a hypothesis before it begins, but maybe we haven't really tried it in humans, or we've just tried it for safety and not for efficacy. So we need to continue looking at risks and benefits all the time. You spoke about this a few minutes ago, that it was important to continue telling the patients about it. And this also, some of our preliminary data that we get back, we need to think about how that impacts patients. So participants may not be subject to increased risk. Participants must be informed of any new findings that could affect their willingness to continue. And disclosure of interim results may be indicated. The preliminary results may indicate that there's a risk balance, that the risk and benefits, are not balanced in the arms. The problem, the sort of tricky bit of all about this, is at what point do you have to tell the patients? If you have had 3 research participants and 2 of them have had a bad result, on the one hand you're like, oh, 66% of our participants have had a bad result. That's an extreme number. We should tell people. However, 3 patients is not very many. You don't really know if that's going to hold up once you've had 30 patients. It could just be like Sometimes results are unpredictable, and if you continue it out to 30, those will still be the only 2 that had a negative reaction. So it's really challenging to know when is the time where you have to say, like, look, stop. We see that bad things are happening, and it's statistically significant. If we say, oh, one person had a bad result, stop the research, I think you need to be careful about looking at the research, but you also have to look at, is this a credible number of participants we've had so far? And that's a challenge in terms of when do you give interim results to patients. So for monitoring under the regs, if it's a minimal risk study, you have a data safety monitoring plan. That's all you need. If it's a significant risk, you need a data safety monitoring board, which usually reviews your research every year or 2. They're independent of your research, often at external places. They'll look at what results you're getting, what protocols you're using. You also have to report adverse events to your sponsor and also to your institution. The IRB does a continuing review. This is a lot of what we do at IRB here. Generally, we do continuing review once a year. What we ask people to turn in with continuing review is how many participants have you enrolled since last year? How many have dropped out? Have you had any adverse events? And have the adverse events, are they related, do you think, to the research? And were they expected from the research? Like, this was foreseeable, this was not foreseeable. How are you keeping your data in order? Sometimes we have problems with people's consent forms aren't in order. They have varying signatures on them. They're not all signed before people begin. So we just want to see that the research is proceeding according to the protocol. And then there can be a possible Office of Research Compliance audit, like an IRS audit. This can happen because like we might get some tips like, oh, this person's research is really a mess. And so we might go and say, we need to audit to make sure things are in order. It might just be randomly we're going to audit your research, because we do that every so often to see if general our researchers as a whole are following their protocols. Part of the challenges, and one of the things that we help people with, like I think people like with an IRS audit are very freaked out, oh, this is a witch hunt. But part of it, a lot of the things we find non-compliance are sort of failures of good record keeping. People don't understand the importance of storing things in a certain way, the importance of getting consent in a verifiable, systematic way. So part of what IRB and Office of Research Compliance can do is to help sort of coordinate all the activities of your research, to coordinate your activity with the other centers if it's a multi-site study, to help the sponsor know that part of their rules do or do not apply here. Any questions about monitoring? So when to stop a trial? Because there are times to stop a trial. Participants should never be subjected to known unreasonable risks. So say we've had 100 patients, and we're seeing 20 patients that's had a really negative effect. That's starting to be really significant. Participants should not continue in control arms when a benefit has been established. Let's say that we're studying a new medication and we are getting fantastic results. At a certain point, we should stop this research and we're saying, well, this is no longer equitable research arms, because we know someone is getting really good results. This has the same problem of when are increased risks or benefits known. This is part of why we also require research findings every year, because say it's a research study that's not very tuned in to what's happening. We want to say, like, look, you're having really great results, or you're having really terrible results, and we need to talk about whether you want to continue. Stopping on a false positive, again, if you've had 3 patients and 2 have had a bad effect, it's really hard to say what that means. And if we stop too early, it could just be it could have just been like a strange pattern that a couple people in a row did poorly. But if we wait too long, it'll be, why are you continuing to run research where you're having terrible results? So at some point, if your results are either really excellent or really terrible, it's appropriate to stop your research. when that time is hard to define. All right, let's talk about justice in research participation and research outcomes. So who should participate in research? Part of it depends on what are we trying to learn from the research. Are we trying to learn something that only affects children? Are we trying to learn something that, say, only affects Caucasians, only affects Native Americans? And does gender matter? I think we all found out in the 90s that studies previously, what had been sort of a typical human in most research in, say, the 70s, 80s, 90s? White men. And so they said, well, if we found this in white men, it applies to everyone equally. And then they started to see that that was not at all true. That people of different race, ethnicity, and sex tended to have different results. Sometimes different medications would impact people differently based on those factors. So our risks, benefits, and shares, so we talked about this earlier too. Is there a reason we're including or excluding underserved populations, or excluding vulnerable populations? Are we excluding prisoners because we feel, you know what, they are really coerced, they can't say no, we want to be really careful and ethical? Are we excluding prisoners because it's just challenging to have to head over to the prison and then we have to go through the metal detector, and that just seems tiring and let's not do it. So it's important to really balance sort of the risks and benefits, because we want to give people from a variety of backgrounds access to research. People, we have established, want to participate in research for all kinds of reasons, and it shouldn't be up to us to a certain extent to say your reason is good and your reason is bad, unless part of the reason is I don't understand the research and I have this crazy inaccurate belief about it. So the balancing protection of the captive and vulnerable, I just talked about this. We need to balance their need for protection, their vulnerabilities, versus the benefits. And so this includes both our, sort of what we talked about earlier, both our vulnerable populations and some that aren't necessarily defined as vulnerable, but that we know are not as I guess, free to say yes or no as the rest of us, like students and military. Something that didn't come up earlier are people for whom they are not fluent English speakers, or maybe don't speak English at all, economically or educationally disadvantaged. We talk about the low health literacy level in Arkansas. That makes a difference. I should also mention people often have numeracy problems also, which can affect, it's hard for them to understand numbers and math, and that can really affect how people understand research participation as well. So Willowbrook, that's what I told you earlier, I couldn't remember the name. Willowbrook is where they gave the children hepatitis. Sorry, I've lost my train of thought. So there's a lack of good pediatric data. We talked about generally what is the standard human, what was it until the 2000s? It was a white adult male. So generally, children with cancer, things like that, we are guessing a lot about how we treat them. There haven't been child-specific research studies, in part because children are such a vulnerable population that there's been a lot of nervousness about doing research on them. Of course, because when we don't do research on them, we don't know the best ways to treat them. So that leads to a great deal of off-label drug use in children. Children with attention deficit disorder, children with cancer, children with epilepsy. We're sort of just based on weight, sort of establishing it from adult trials. So we have started to see there is need for specific pediatric research studies so that we can better treat children with these terrible diseases. And then generally, if you have capacity and you have autonomy for yourself, you can make any decisions for yourself. If you are a surrogate for someone else, we let you make a large amount of decisions. If you're a parent, your role is a little bit different. We don't let parents actually make as many decisions for children as we let parents make for themselves or for another adult, because as a society, we see children in need of some protection. And also, I'll talk a minute about assent. is that the research regulations require that we ask children for their assent. And so what role should it be if children don't want to assent, but parents do? So let's talk about a randomized controlled trial. A proposed research protocol comes before the IRB involving the use of 2 chemotherapy drugs used for the first time together. This is a 4-arm randomized double-blind trial as follows. So a quarter of them are going to get these 2 drugs together. A quarter are going to get drug 1, a quarter are going to get drug 2, and a quarter are going to get placebo. We really don't know which of these arms is better. None of them work really great. So patients are to be drawn from both adult and pediatric populations. The trial only takes patients who have failed twice on other standard chemotherapies. So we're really not sure what works for these patients. Stephanie Smith is an 11-year-old whose cancer has not responded successfully to the previous 2 attempts with chemo. Her oncologist mentions to her parents that there may be a new experimental therapy and is under review at the IRB. Her parents are interested in getting the therapy for Stephanie, but when talking to Stephanie, she is tired of being sick all the time and wants to stop all the medications that make her too sick and make her throw up. So what is the ethical way to proceed? We have this trial. Do you have concerns about this trial, first of all, the way it's set up? We have 4 arms. These are patients who have failed chemotherapy at least twice.
Well, you're including adults and pediatric populations. How are you going to adjust the dosage for that? Because there's a huge difference in the dosage you give an adult to a child.
So the question is, if we're enrolling both adults and child, how are we going to adjust the dose? And it's in our protocol. We have something based on weight. We're going to calculate some things with numbers.
Well, obviously, the patients who need chemotherapy, so giving them a placebo is problematic.
Okay.
Maybe if they receive a tandem combination of a placebo plus therapy 1, placebo plus therapy 2, they're getting a therapy. I guess it's the same.
So the comment is, well, these are patients who need chemo, so we shouldn't give any of them placebo. What do others think?
This looks like she already responded to 2 rounds. Did she respond or did she not respond?
She did not. She's not responsive. So to go back to your, do we know that all these chemotherapies are going to help people? No. That they're going to be better than placebo? In this case?
Well, we would know that therapy 1 or therapy 2 could help people because then they won't be as sensitive.
Well, they help people who have cancer. We don't know it helps people who've had 2 failed chemotherapies. We're trying to help these people who have multiple recurrences. So we know therapy 1 and therapy 2 work. We don't know what works for people who need a 3rd line of therapy. And is chemo always better for cancer patients than no chemo? It is not always. For certain cancers and combined with certain chemos don't work at all, only they make you sick and terrible. So back to Stephanie. How should we proceed here? Who is the person who gives consent here? The parents. And what are they saying?
They're saying yes.
Okay.
Stephanie says no.
Stephanie says no. Do we care?
Yes.
Okay. Well, she's 11. What do they know? So the comment is she's legally allowed to give assent or not. So what does that mean?
You can say, I don't want to do this.
Yes. So she can say, I don't want to do this, and then what?
I think that needs to be weighed.
Okay, it needs to be, someone said then it should stop, and someone said it should be weighed. Those are different statements.
I think if on the research cannot value one over the other.
Okay, so,
Have both, she's not in the study.
okay, so, the comment was, as a researcher, it's our job, it's the researcher's job to make sure that, things are proceeding ethically, and so we need to have both consent and assent in order to proceed.
At the same time, perhaps for MD or a therapist or somebody could talk to her and evaluate if Stephanie is able to, like, if there are other factors contributing, and maybe they can at least talk to her about it, and her parents can help her come to a better assent or, like, you know.
Okay, then there's a suggestion to have someone come in to speak to Stephanie, like maybe therapist, play therapist, someone, to see if they can understand, if she's able to understand this. Other thoughts? Yes.
Well, we could send a child, I mean, but you could have a conversation with both the parents and the child, that's part of the consent and assent process.
Yes.
It still says no, I mean, you can't enroll a child that's declined. You can't enroll a child just because they're parents. Well, yeah, how do you love just because they're parents?
So I'm hearing people say that we should speak to both the parent and the child, but if she doesn't agree, we can't enroll her if she doesn't agree.
Is there a consent age for treatment?
Yes. What's the consenting age? The question is there an age to consent for treatment? I said yes. What's the age to consent for treatment? To consent for treatment, what's the age? Consent. Consent. 18 years old is how old you need to be to consent. So assent, people are telling me, are 7, 10, 12. 7.
What about competency, like, is she competent to actually take a decision like that for herself?
So then the question is she competent? Well, what do we know about competency, first of all?
It has to be judged or somebody.
Competency is a judge, so we're going to throw that away. What are we going to talk about? Capacity. And what do we know about capacity? The doctor can determine it, and in general, children do not have it. There's some question I would tell you about what age they get it. Very few people will tell you, very few, an 11-year-old has it. All right, so keep this in mind. We're gonna go to our next slides and talk some more about this. So assent is defined as a child's affirmative agreement to participate in research. They say, yes, I'm willing to do that. This is what the Code of Federal Regulations says about assent. The IRB shall determine that adequate provisions are made for soliciting the assent of children. What does that tell us about? Does that give us any insight into the case of Stephanie? So what's the law telling us we have to do? It's saying we have to ask children for their assent. What does it say about the response we get? It says nothing about the response. The regulations say nothing about it. It says we have to ask for assent, and that is all it says about assent. It says, like, you should try to get assent in an age-appropriate way, but that's all. What is an adequate provision? What does a child need to understand? Because assent is not the same as consent. So what's different? We don't really know. So what makes assent meaningful? So this is not part of regulations. This is part of the National Commission of the Protection of Human Subjects, of biomedical and behavioral research, that government board we talked about 100 years ago, like 3 hours ago. It should describe the research protocol and explain that the minor's participation is voluntary. There is no nationwide standard age of assent. Minimum ages in the literature range from ages 3 as a minimum to ages 12 as a minimum. The American Academy of Pediatrics, the National Cancer Institute, and the UAMS-IRB generally rule that age 7 and older should be asked to assent, because psychological research shows that age 7 is when you start to have sort of concrete thinking, where you can think about future things where it's not all just the here and now. What factors should the IRB consider when setting an assent age? Part of the reason, the risk is a good idea. Part of how we arrived at age 7 is, you know, sort of how the brain works, the brain development. But we also know 7-year-olds are not like full of excellent logical, concrete thoughts. So the risk. Other thoughts? Literacy. I think that's important. You know, 7-year-olds vary. 7-year-olds, 10-year-olds, 11-year-olds. You know, the process of learning to read is a several-year process, and children arrive there at different speeds. So after sort of learning about assent, what do you think about the case of Stephanie now? I will, pardon, I didn't mean to interrupt. Go ahead. They asked her, so they definitely should ask her for her assent, and then she said no. And then what should happen?
In the setting, and she works with her physician to come up with her plan for her treatment.
Okay, so the comment was she should not be in this study because she said no, and her physician should come up with an alternate plan.
I really like her idea of bringing in a third party to talk with her separately to make sure she has a full comprehensive understanding of all her options at her level of understanding for an 11-year-old child.
Okay, another vote of have someone else come in and talk to her about it at her level. What if that doesn't change her mind?
Then I think that we should respect her wishes.
Okay.
But more importantly, what if she does change her mind? And I think that third person is your research design budget allows for that.
Sure, we have a giant sack of money.
Yeah, allows for that, it's also not the other way, that the parent, you know, unduly pressures their child to be in the study because as a parent, they really want them to be safe.
Right, the comment was we should
Made about this.
we should be careful not to let the parents unduly influence the child too much. What do you think the parents will say when we say your child has recurrent cancer? She may be dying. We have this research, but I don't know. She said no. What are we going to hear for the parent? Enroll my kid. She's only 11 years old. 11-year-olds don't know. I said yes. I'm in charge. I think it's important to tell you that under the regulations, we could just go right ahead. The regulations don't say, it says you have to solicit assent for a child. It doesn't say you must obtain assent from a child. I have a lot of issues with the idea of assent, and this is one of them. Like, if we're going to get assent, if we're going to ask for assent, then it should be meaningful. And if we're going to just ignore it when it's no, what is the purpose of getting assent? On the other hand, an 11-year-old cannot consent for their own medical treatment, so should they be able to overrule their parents for research? And I think the arguments are, well, research is not necessary to their clinical care. It's sort of optional. It's not a sure thing. So if a child doesn't want to, we should allow them to make that decision. It's not same as, are you going to get a flu shot or something like that. So that's part of the issue. On the other hand, Stephanie, what do we know about her? She's been sick a long time. So she probably is more savvy than your average 11-year-old. And is that something, she's gone through chemotherapy twice already. She knows something about it. So is she someone we should be listening to at a different level than we would listen to a different 11-year-old? I think that's all the complicated parts of enrolling children. But as I said, right now, generally, we ask children's assent, but a lot of research I'm aware of, especially if it has a potential therapeutic purpose, such as Stephanie's case, if a child says no, it doesn't always halt the research. Other questions, comments? I'm running way behind time, so we'll just look at longingly at my cartoon and not take a break. Sorry. I'm too chatty. So non-therapeutic research with children. So we're talking about Stephanie, and there was a potential that was therapeutic, that was going to offer clinical benefit. Potential, not for sure, that's why it was researched. So George is 3 years old and he has disease X. Disease X is fatal in childhood 100% of the time. Researchers want to enroll him in a research study that will involve repeated laboratory testing. These tests may cause discomfort, but it's expected to be temporary, and it's hoped that this research will benefit disease X sufferers in the future. Should George's parents be allowed to enroll him in this study, and how did you arrive at your answer? Only half hour left, people. Dig in. Cam's going to give you another Tootsie Roll now. That'll make you excited. She knows what we need. I should have like a little carrot I come in with. All right, George.
Should they be allowed?
Yes. Is this a study that should even exist? Is this a good ethical research? I'm stepping away from the podium. Sorry. I was warned about that. Is this research that should be allowed? Is it good ethical research design? Or do you want to say, if you don't want to weigh in, what are reasons this would be okay? You don't have to decide on the whole research, but just what are some factors that make you say, that's in the yes column? Say it louder. It's a fatal illness, and when is it fatal? In childhood. So if we don't study children, we're not going to get to study this disease. So I think that's in the pro column. Excellent. What is another pro reason that this might be okay?
It'll help people in the future.
It'll help people in the future. That's what research is about. We do not want children to continue dying. Oh, I see a question popped up I could see. It said, what kind of laboratory testing? And how, I don't know how I could magically see that. Maybe I haven't been looking before. What kind of laboratory testing will happen? I don't know. Does that make a difference to people?
If it's minimal risk, might make a difference.
Like, what if it's a lab draw, like a blood draw versus a spinal tap? That's a big difference. That's a good question. I know, so. Okay, oh, tempting me. Like, if you do a good job in the last 30 minutes, Leah, you can have that. So I think it's an excellent question to ask what kind of lab test. So let's say they're blood draw.
Then the risks are very minimal. Yeah. So I think it would be okay.
Okay. I read half of the question popped up here. I maybe missed the second half.
What kind of laboratory testing,
Okay, that's the part I got.
and are they already part of standard of care?
Are they already part of that is an excellent question as well. I'm going to say it's a blood draw, and it would be in addition to standard of care.
And the third part there,
Oh, there's a third part.
yeah, what kind of discomfort?
You know, he's 3, so he's probably going to freak right out. He's maybe going to freak out before it even happens and lie on the floor and scream. Because, you know, 3-year-old's going to do 3-year-old things. So it seems to be that the general belief is that's minimal risk, we'll allow it. What if it was something less minimal?
Still needs to be considered because it's something that's fatal in childhood, and we need to be able to study children to figure it out.
So we're still going to consider it because of it's fatal in childhood. And I think that you're right to point that out. Part of what we say about non-therapeutic research with children is that generally it's not allowed unless it's the only way to help either that child or a child similarly situated, which is like disease X if we don't study some children with disease X, we're never going to learn anything about disease X. So we may be, you know, a healthy, unafflicted child, we would say, nah, this is not okay. But unfortunately, we might need to allow it just because that this is a disease that's fatal in childhood. Oh, this is the part, do we have sound in here, Kim, where I can show a video?
Yes, you should just go to the internet and you figure out.
Okay, sorry. All right, let me read the slide first. Sorry. Josh Hardy, he's a 7-year-old. He's been battling cancer most of his life, right up the road from us in St. Jude's in Memphis. He's recovering from a bone marrow transplant. He has adenovirus, which a regular child could handle okay, but since he has no immune system, it has made him very, very ill. He's unable to tolerate the standard therapy cidofovir, but his mother, she has an idea for what he needs. Now can I just clickety on this? Oh, okay. I should be able to,
Josh
here we
Hardy has
go.
been fighting for his life since he was a baby. Overcoming kidney cancer 4 times, and heart failure, and now undergoing a bone marrow transplant. But now, the drug he needs to survive, a very curable virus, is being denied because the manufacturer says it can't afford to give him the drug. So, will the drug company step up to save the life of this little boy? Josh's mother, Amy Hardy, joins us now. Good morning, Amy.
Good morning, Jim.
Your boy Josh has fought cancer 4 different times. He developed it as a little boy, heart failure, a bone marrow transplant, and now he's suffering what's called an adenovirus that's put him in intensive care. Why will the drug company not give him, as a compassionate use, this drug that he needs to survive?
They've definitely given excuses, but nothing is acceptable to us. This is our child's life, and we just feel compelled to just keep asking for it and begging for it because he needs it. He absolutely needs it. If he does not get it, he is going to die. And I just feel that where there's a will, there's a way. And our will is very strong, and we're going to keep on asking and asking and asking until they hear us. I know they hear us, but until they release it for us.
Now, you've asked the people at the company called Chimerix to give what's called compassionate use. Even though it hasn't been approved by the FDA, they've given compassionate use hundreds of other times in other cases, but they won't give it to your son. Hear what Kenneth Mock said. He said, as a small company with limited resources, we made the difficult decision 2 years ago to end our compassionate use program and focus all of our efforts on earning FDA approval for brincidofovir. This is the only path to making that drug widely available to those who need it in the fastest manner allowed. So the question for you, Amy, is when a company like this gets $72 million in federal funding, do you think they have a moral obligation as a good corporate citizen to help your son stay alive?
Absolutely. I mean, again, I feel that it's just an excuse, and we need them to totally change their stance, not only for us, but for, hundreds or even thousands of people that need it. There's got to be some other way that they can make this available to everyone, because it from the studies indicates that it's very successful. It's one of the only products on the market that can treat a virus, and it's almost to me it's almost a crime not to make it available to everyone who needs it. And I definitely am going to keep fighting for my son until they get it.
I asked the president of the company, Chimerix, Mr. Mock, over the weekend whether, if in fact a visit to visit your boy Josh Hardy at his bedside in St. Jude's Hospital in Memphis would change his mind. He said it would not change his mind. How would a visit change his mind? What would Mr. Mock see today if he went to see your little boy? boy, Josh Hardy?
He would see a frail little boy who has a very weak voice and has a hard time staying awake because he's in so much pain. And to combat the pain, he has to be on a lot of pain medication. So he's drowsy. It's horrible for us as parents to see because he is a vibrant, strong little boy. And even though he is frail, he has a very strong will about him. But you know, things just keep stacking against him, and we just want to do everything we can to give him the opportunity to make a full recovery so that he can play baseball, he can play basketball. We as a family, the 6 of us, can be in the same household again. This is an extraordinarily hard process for us, and I'm grateful for you to have us here, but I want to be by his bedside, holding his hand and telling him it's going to be okay. But because of this unwillingness to release this drug, I have to leave him and come talk to you, and it infuriates me.
Well, thank you for coming to see us, and we wish your son all the well. And as part of that process, in that effort, you've asked us to show the information that you think can help. You can call Chimerix at 919-806-1074, email them at compassionateuserequest@chimerix.com, or tweet at Chimerix and use the hashtag #SaveJosh. Please let us know what goes on day by day with your lovely son, Josh, and we'll stay on top of this as well. Thanks, Amy.
Thank you, Peter. Actually, I'd like to add, if you could just follow us on Facebook at hashtag #SaveJosh.
Okay. All right, so what did you think of that video?
Hard to watch.
Yeah. Why was it hard to watch?
Bad question. Poorly asked question.
There was a lot to unpack about that video. Yes. Do you want to elaborate?
There was a lot of redundancy in the questions that he was giving. A lot of them were kind of leading and kind of biased, and you know, we don't know the full story. $72 million for a company like that may literally be not much money, but to the general public, that's a huge amount of money.
I would welcome someone giving me $72 million for my research. Yeah.
Right.
So what is the story that clip is telling you? What are we walking away from? Do you think we are meant to believe?
That drug company seeking treatment,
That there's
life-saving treatment.
Yeah.
there's a
Innocent child.
drug company keeping life-saving treatment from an innocent child who, by the way, don't know if you noticed, is very adorable. He sometimes holds a puppy. Yes, has brothers and is baseball, like adorable.
And they have a compassionate program, I mean,
They've helped others with their compassionate use exemption.
So why stop now?
But they signed a contract when they got that grant that probably said they could do it.
Yes.
It's possible that the company is losing money and it's part of their strategy. They mentioned one medicine there, because as a CEO, for example, he has to address also to the board members. That's how the company works.
So that
In as much as he would like to help, it's still the decision of the top management.
is it possible that the company is losing money and they're having to answer to their board members, their management? Part of the story that Chimerix told was, we're trying to go for FDA approval, and if we're stopping to build more compassionate use studies, that is interfering with our efforts to get FDA approval.
Yeah, because I was gonna say, they are probably, or have been losing money on the drug development because they're in the research and development phase. So they're not even in market.
Right.
That particular drug.
So someone else mentions
They
that
don't even have FDA approval, so they could not,
they've
been losing money on that drug.
they're not in the money-making phase because they're still in the research phase. They're not going to be in the money-making phase until they get FDA approval. Yes.
I can't remember, but 10 years ago I came up with I saw an article about the approval process of the drug.
Mhm.
Usually there are like about 100 candidates,
Mhm.
and as time goes by, it's chopped down to 1 or 2 promising until there's really a successful FDA,
Mhm.
and they computed that for one approval, it can cost, I think, 10, 20 million.
So we're talking about the cost of FDA
Investment,
approval
the investment, yes.
can cause tens of millions of dollars. Do you think the $72 million that Chimerix had was all going towards this medication? We're led to believe that, but I think we don't know that. Other comments? Right, so the comment is we don't know for sure it would actually help him. Did his mother or the host mention that this is not an approved treatment for his adenovirus?
No, actually, they make it sound the opposite. It's the only thing.
They make it sound like this is a sure thing medication, not that we would like to give this unproven, un-FDA approved medication to our child who is admittedly dying. So from 2009 to 2011, Brincytovir was available under an extended access program for treatment of serious DNA viral infections and via emergency individual investigational new drug exemption. So it was available for people like Josh. Chimerix stopped accepting new requests in 2012 in order to focus its time and resources on obtaining FDA approval, because they felt that process would ultimately serve more patients. The social media uproar was so intense that Chimerix ultimately reversed its decision and put together a 20-patient open-label pilot trial so Josh could have the drug. The CEO started getting death threats after this aired. So when should patients have access to unproven therapies, and who should decide who gets experimental treatments? Should that be a pharmaceutical company, the FDA, someone else? Why do you think that this worked for Amy Hardy? And if you were Chimerix, would you have made the study medication available to Josh Hardy?
Worst job in the world.
Some comments, it's a terrible job. So why do you think that video was successful? So it was in the media, it went worldwide. It made it sound, like we said a minute ago, like it was, they were withholding life-saving drugs from a child. Are there justice issues about how this happened? About how, I mean, I'm not faulting Amy Hardy, because heaven forbid my child, lie, cheat, steal if you need to get it. So she's doing her thing. Was it just how it happened? Why do you think it was successful? Number one, they got on TV. Number two, she was well-spoken. Number three, they had a bunch of really cute pictures of him and also him looking really sick. So there's a visual to it. Do you think there would have been the uproar if all of that had not happened? Someone had a hashtag on Twitter about their child. No. So is that just?
If it saves his life.
If it saves his life.
Well, not all children have access. They kind of had a pseudo-credible journalist who has some level of authority saying they're wasting their time by saying this is not fair. But not everybody has that type of advocate understanding.
Right. The comment is not everyone would have this, which is true. We can assume that every parent whose child's recovering from a bone marrow transplant and gets adenovirus wants everything. But they don't all for whatever reason, haven't made this work in the same way. And what does it tell the general public about research and how research works and what a compassionate use exemption is?
Well, it kind of villainizes the research.
So it villainized the research industry. I think we talked a minute ago how it really made it look like this is just a sure thing. It's as if they're withholding amoxicillin from him. They're not talking about, this is something that has not been proven at all. Not been proven safe or effective. So, but the way it made it sound is look, we have our child and he's dying. So they did give it to him and it did work. He has now died, but probably, I think he died a year or two ago, so it's about 3 or 4 more years that he lived. So there is I think the medication has never been approved. They never were able, after this they had a number of problems. They had a financial problem, they had obviously a bunch of PR problems, and so it never got full approval. Their CEO, after he got the death threats and he made the medication available, he was forced out. So there's a number of repercussions, but I think it's so interesting because it tells a story of research that, for people who work in research, is not accurate, because it's saying we have something we know will work, and they're keeping it from us, and they've gotten $72 million from the government. And that's not quite the accurate story. And also, if we want these companies to get approval for their medications, you know, they have to go through this expensive and time-consuming process. And it's also true that doing this delayed their process. It took them extra time and money. So. Right. I mean, I think part of it is their studies were not showing a lot of awesome effects, but it did have a derailing effect to them, that they were on track to push it forward and it didn't happen. All right, I'll try and speed up. So we talked a bit about what we're paying for when we are paying people for participation. Are we paying for their time and effort? Are we paying for their expenses to get here? Are we paying because we really want them to participate in our research? And if, you know, a little bit of gift card helps, we're happy to do that. And how much is too much? And when does money go from being an appropriate remuneration to being coercive? And of course, the problem with that is if you asked all of us in this room, you're going to get, you know, a different answer from all of us. Some of us would say, well, $20, $50, $100. If you have to stay overnight, maybe a couple $100. And then that's getting to be nice money. This is another reason college students participate, where they give blood plasma, like fast money. So compensation for research injury. Serious injury is rare, especially for healthy volunteers, they generally test safety. But there's little systematic information about the type, frequency, and severity of injuries. It's also unusually, I think it's a little bit surprising that guarantee of compensation for research injury is rare. Generally, what a lot of consent forms say is we will give you immediate medical care if you're injured. We'll give you rehab, sometimes lost income, but it's also sometimes hard to prove, oh, I was part of this research study 5 years ago, and now I have a disease that is maybe related or maybe not. Part of the problems is that it's unknown what the liability is, both for participating in research or for doing research. Again, this is something that there's not so much regulation, it's sort of controlled by our court process. There's uncertain causation. You know, a lot of diseases, complex diseases like cancer, are multifactorial. Did you get cancer because you tested our chemotherapy 5 years ago, or did you get cancer because you live next to the nuclear power plant? It's hard for us to know. And therefore, adjudicating claims, going through the court process, how much do we owe you, is expensive and difficult. So part of the solutions are to require private insurance coverage and cover others under a pool. I have half of a word there. Or to create a national no-fault insurance pool. All you insurers, you pay into this pool, and that will encourage people to participate in research, and that if they're injured, they will get money from the research participation pool instead of having to go through the court process, which is expensive for participants to take part in. This hasn't happened yet, but is a potential solution. So a survey of 129 policies in academic medical centers find how do they handle research injuries, found that just over half provided no free care, which I think is a little bit troubling. 16% provided some free care, which is mostly just like emergency care or medical treatment. Like if you get sick right now, we're going to take care of you. You know, if you have an allergic reaction, right, while we're giving you an infusion or medication, we'll give you some Benadryl. We'll take care of that. 10% will either bill your insurance and offer it free if you're uninsured. And, of course, the problem is, what's your insurance going to say? That was for research. We're not paying for that. Billed on a case-by-case basis, 4%. And decline to answer your persnickety questions, 18%. So really, I think looking at that, I mean, do you think that researchers have an obligation to care for patients who are harmed during research? Or is that just when you participate in research, you know the potential risks, and that's up to you? What do you think?
No, as researchers are tasked to protect our participants.
Okay.
Making sure that they don't receive unnecessary harm, and if they are, we need to amend that.
Okay, so the comment is our obligation is to protect research participants and to make sure they are not receiving unnecessary harm. They're not necessarily not receiving unnecessary, that didn't make sense. But just because they're injured doesn't mean the researcher is not taking care, is what I'm trying to say. But you would say obligation is to treat. Other thoughts? You know, I would tend to agree if someone is, to me, is acting altruistic and trying to help, they should not incur costs by being in research. That's part of why we give them a gift card or a gas voucher, a lunch voucher when they come, and to say, well, if you get hurt, best of luck. The fact that only half provide care and it's very limited, are people surprised? There's some surprise. So who has knows about? We'll end talking about Henrietta Lacks. Who's heard about her? Okay. If you are interested in an excellent book about part of the history of medical ethics and research, I recommend The Immortal Life of Henrietta Lacks. She died fairly young of cervical cancer. I believe she was in her 30s or maybe even 20s. Tissue from her cancer was given to a researcher who was looking for cells that would last indefinitely. She had an unusual type of cell, and they were named HeLa after Henrietta Lacks. She did not consent to her cells being taken, and the family was unaware of the existence and use for at least the first 20 years of their use. Vaccines and other discoveries representing billions of dollars have followed from the 60-year use of HeLa cells with no compensation to the family. There is almost too many medical discoveries to count that have resulted from HeLa cells. They're still used all over the place, all the time in medical research. It is almost impossible to oversell the impact she has had on medical research community. Eventually, when it came out and this book was written in the early 2000s, the families did get a settlement, an undisclosed settlement. I think we can all pretty much be rest assured it's only a tiny fraction of what she has made for the medical community. I mean, not only financially, but has also really helped our understanding. But so part of this really opened up when it came up a big discussion about, you know, she was young and she was not very, you know, that she seemed an easy person for the medical community to take advantage of, and they went ahead and did that. And hopefully it would be different today, but I think when we look back on everything we've discussed in the last 4 hours, we see there's lots of times where the medical community and research community as a whole has said, oh, you don't need to worry about us. We are totally would never do anything wrong. And not always because people are malicious, but people are people, and they're looking for easy shortcuts. They're you know, we're all trying to publish, we're all trying to get results, we're all trying to make advances, and the easy way is often not the most ethical way. So before we finish, I know everyone's really depressed. I didn't get to the end of the slides. I'm sorry, too chatty. I want you to know that for everyone involved in research, I think I mentioned this last time, if you have concerns about research you are involved in, you see your family is involved in, there is support for you at UAMS. You can call the Office of Human Research Protection. You can call the IRB. You can call me. I'm in charge of research ethics here at UAMS. My last name is Eisenberg. I think you have it on my slides. Feel free to email me at any time if you want to talk about something. I'm not at all kidding. I'm here for you. If you want to have coffee and talk about something troubling, if you want to just talk on the phone, do not be a stranger. I know often when you're in a lab, it can feel like you're on your own and there's a big PI against you. And I want us to have a culture of ethical research. And if there's any way I can support you or your lab or your people in doing that, let me know. We can just chat. It's not like I'm going to tell everyone you called me. If you have concerns, other people have a concern, and you are part of the front line in making sure we have ethical research here. So again, reach out to your resources. Don't hesitate to contact me or others. I tell this to people about ethics consults, clinical side too. Let me be in charge of if it's a silly question or not, or if it's a question for me or not. If you have a thought you'd like to share it with me, go ahead and don't be nervous about it. So thank you. I know 4 hours is long, especially because I'm very chatty. I appreciate everyone coming and participating, and I hope to see you again. Enjoy the rest of your day.